Hello, my name is Arndt Vogel. I'm a hepatologist from Hannover in Germany, and it's my really great pleasure to welcome you to this webinar with a focus on immunotherapy in cholangiocarcinoma. And I think we have an excellent speaker who is well known, Kelley from the University of San Francisco, and she will give a talk on the challenges of designing immunotherapy clinical trials in cholangiocarcinoma. But this is supposed to be a very interactive session. So whenever you have any questions, please feel free to ask them, and you can also send your questions into the chat. So with this, I think we can start right away. Katie, please.
Thanks so much, Arndt. And it's a pleasure to be here. Thanks to the Chlangiocarcinoma Foundation and ICRN for the invitation to speak today. And I likewise am thrilled to have Arndt as a host and moderator to also ask questions of him along the way, since he is quite an expert in this area. So the title of the talk, as Arndt said, is Challenges of Designing Immunotherapy Clinical Trials in Chlangiocarcinoma, with some focus on second-line context, but really discussing along the breadth of treatment context here. So here are my disclosures. So the objectives of today's talk, first I'll begin with some brief background on the cholangiocarcinoma immune microenvironment, really, which sets the stage for how we approach immunotherapy and also introduces many of the challenges we face. Then I'll spend some time discussing the data we have on clinical trial outcomes of immunotherapy for cholangiocarcinoma, beginning with checkpoint inhibition or ICI, immune checkpoint inhibition ICI as monotherapy, as well as combinations in clinical trials. And then we'll discuss in a more interactive fashion the challenges and opportunities in studying immunotherapy in the second-line context, and conclude with some future directions and discussion. And again, please do enter any questions along the way in the Q&A function and chat in your Zoom screen. So beginning with some brief background, I think this is very well-known information to the audience today, but biliary tract cancers are both uncommon and very heterogeneous, which makes them very difficult to study in clinical research. The incidence, despite being uncommon, is rising, now approaching approximately 15,000 cases per year, depending how we subdivide in the US, combined across sites. That includes gallbladder. Etiologies, most cases are idiopathic, but there are also heterogeneous risk factors ranging from a variety of types of liver inflammation and injury, including non-alcoholic fatty liver disease or NAFLD, hepatitis B virus or HBV, hepatitis C virus, HCV, alcohol, primary sclerosing cholangitis, fluke infections, and also hereditary mutations. Now, the anatomic location of cholangiocarcinoma can occur anywhere in the branching structures within the liver, shown with these little green lines here within the liver, as well as at the entry of the bile ducts to the liver. So the dark green here are called intrahepatic cholangiocarcinomas. The lighter green are called perihilar, or with the eponym Klatskin cholangiocarcinomas. And down in the blue, as one approaches the pancreas, are the extrahepatic distal cholangiocarcinomas. These locations both impact our clinical treatment and comorbidities, including risk of obstruction, the risk of liver dysfunction, risk of complications like infection, but they also can impact the mutational landscape of the tumor, in that we have learned over the past few years that the genetics of tumors arising in the tiny bile ducts within the liver can be very different than the genetics of tumors arising in the distal bile duct, for example. So all of these factors contribute to a very heterogeneous landscape within this fascinating but difficult family of tumors, I should say. Now, turning to another important part of this heterogeneity, the immune microenvironment of cholangiocarcinomas. I wanted to show this brief snapshot, which exemplifies another type of heterogeneity that we have to think about when we talk about immunotherapy in particular. So I'm showing here results from a study of around 566 intrahepatic cholangiocarcinomas, starting with a small institutional cohort that was validated in a ICGC external data set. And what the researchers in this study did was to perform stromal and tumor transcriptome analysis and profiling of the immune cells in these samples, starting with their training set and then validating. And they defined 4 different immune subsets that were quite different from each other, including the most prevalent were an immune desert without really any active immune cells. So this is sort of a so-called cold tumor that are very challenging for immunotherapy because there's really no immune cells there to act. Then that they called the I1, just for sake of discussion or reference later. Then there was a very intriguing subgroup of around 9 to 13% of samples, 11% overall, I believe, that they call the inflamed or immunogenic I2 subgroup. And if we look at the immune cell subsets and the staining, we can see that there are a lot of T cells and other active immune cells in this subgroup. And that suggests potential for immune response to immunotherapy. And then 2 other subgroups of interest, but again, distinct from the others. One had more myeloid cells, which tend to be more immunosuppressive, and then a more fibrotic or mesenchymal phenotype, similar to the cold type tumors we're used to. So again, highlighting another type of heterogeneity in this family of cancers that we need to account for. Now, as we think about immunotherapy, we also need to account for the very different types of etiologies that can lead to cholangiocarcinomas that can impact the immune microenvironment as well. And so this is a snapshot of some of the more common etiologies that we have to deal with, and shows how different they can be. And so this is an ICGC study by Jusical et al. That was published in 2017, which has provided us a very important baseline for studying the different epigenetic and genetic and subgroups of cholangiocarcinomas in a large, over 500 patient sample. And the points I wanted to show here are that in the groups that are identified as mostly fluke positive, often from Southeast Asia, we can see the highest number of mutations. Those are often tumor types. High mutation burden, we know, can be associated with response to immunotherapy. We also can see differences in clustering according to viral etiology here, which is shown, viral hepatitis is shown in the cluster towards the left as well. We know from research largely in liver cancer that viral etiology may also impact the immune microenvironment, and then that driver mutations could also impact the immune microenvironment, including immunogenicity and mutation load. And so we don't really know exactly how each of these different variables impacts specific response to immune checkpoint inhibition, but we have reason to think that they could. And so we have to take those into account as we approach immunotherapy in cholangiocarcinoma. When we look at the biomarkers that we know most about from other tumor types for response, predicting response to immune checkpoint inhibition or ICI, these include a factor called tumor mutation burden, the proportion of mutants per megabase of normal DNA in a tumor. Shown here on the right, cholangiocarcinoma falls really among the lowest of tumor types with respect to median tumor mutation burden. This is work from Mark Yarshwan et al. At Hopkins. So again, we can see that on average, cholangiocarcinoma has a low tumor mutation burden, predicting less likely to respond to immunotherapy. Likewise, if we look at tumor PD-L1 expression, which is a target for immune checkpoint inhibitors, we similarly see that cholangiocarcinoma is relatively low among the tumor types that don't typically respond to immune checkpoint inhibition. And then I'll show a little bit more about data for response in microsatellite instability high tumor types in general, as well as cholangiocarcinoma. But this is an established biomarker for immune checkpoint inhibitor response. And again, unfortunately, cholangiocarcinomas are quite low in terms of proportion of patients with this immune predictive biomarker for immune checkpoint inhibitor response. So just to summarize this portion of the background, cholangiocarcinomas are predominantly cold tumors. A subset may be inflamed or immunogenic. Only around 2 to 3% have high microsatellite instability. And again, we don't have quite an exact proportion, but high tumor mutation burden is quite rare. So I guess I wanted to pause here and ask Arndt if there are other subgroups of interest that you think may have a distinct rationale for immunotherapy in cholangiocarcinoma.
Yes. Yeah, first of all, thank you very much for this first part. And I think it's, very interesting. So when we think about immunotherapy, you will get to the clinical data in the next part of your talk. But we already know that there's only a minority of patients that will respond to immunotherapy. So we are looking for a biomarker in the end. And I think this is more or less the topic of your introduction now. So can we, from the data we have, is there anything we could use as a biomarker to guide our treatment? Yeah, and if you take everything together, we have different levels. First of all, we have location, intrahepatic, extrahepatic, gallbladder cancer, if you like. And I think it's very difficult to estimate whether there are any significant differences based on location, I would assume, right? And then you mentioned we have gene expression data, which I think are a little bit difficult, and maybe we can think a little bit more about it. so, I mean, this is a mixed group of patients. It included all different kinds of intrahepatic and extrahepatic. Yeah, and I think even if you would start with intrahepatic, it's still a heterogeneous tumor, right? So, and I think this is something which makes it even more difficult that we have so many different subgroups just based on location, genetic profile, and most likely also the gene expression signature. And then what you mentioned, TMB and PD-L1, I think they're also not really usable because, I mean, we don't have so many tumors with high TMB high. And even if there would be some tumors with TMB high, I think we still do not really know whether they would respond to immunotherapy. Yeah, so I think the debate is still ongoing, whether really this cutoff of 10 is sufficient for all tumor types, and most likely it's not. And PD-L1, I think it's also a very interesting point. And you mentioned PD-L1 expression on the tumor cells. I think we also need to distinguish PD-L1 expression on tumor cells, but also immune cells, macrophages, for example. And then we have here different scores, tumor expression, immune cell expression, combined scores, and still nothing is really established. Yeah, so yeah, I'm repeating what you have said. There's a lot of ways to look at this, but in the end, in cholangiocarcinoma at the moment, it's really quite difficult. Yeah, and having said all this, yeah, my question would also be, based on what you have just said, what would be your best guess? What could be a biomarker? So would you think is it PD-L1 expression? Is it genetic background? Or what would you think could be most likely be?
Well, in the next section, I'll show the monotherapy data we have, which suggests a trend towards increased PFS or prolonged PFS and increased response rates in the high PD-L1 subset. It's a difficult biomarker because we don't often have a lot of quality tissue to do the analysis. And we have some internal data on heterogeneity and time points of baseline compared to metastatic site. They're not always concordant, which raises another challenge, but at least, again, that's unpublished small sample set data from some of our own trials at UCSF. But that said, I think that's one, and we'll show that data in the next section of the talk. I think it's, really intriguing to me is, one of the things I think we can do to try to get more information and wrap our heads around what subgroups to be looking at, is perhaps look at patients that we think are less likely to respond and then select them out rather than select folks in. And I think one candidate group it may be extrapolating from lung cancer as well, patients with a single driver mutation. If we could look in large studies such as the monotherapy studies we're about to talk about and see how the FGFR2 fusions perform, for example, in the IDH1 mutations, we might get some information about specific subgroups that have a single driver and low mutation burden or low immunogenicity that might be not a good strategy, and help us focus on those who are. So I don't know what your thoughts are about the driver mutations.
Yeah, I think that's very interesting, and maybe we can discuss it later on when you are talking about the different combinations. And then, I mean, that would have been one of my questions to you, whether we should combine the targeted therapies with checkpoint inhibitors, and then, I mean, then we can maybe dive in a little bit more in detail. And maybe just staying here, you showed these different infiltration of immune cells in the tumor. So do you think, and it's just guessing, of course, I mean, do we need more markers? Maybe it's not just one, not just PD-L1. Maybe it's a mixture of different markers that we need to look at. I mean, we have a lot of macrophages, for example. We have the T cells, of course. We have other checkpoints, LAG3. So could you imagine that? And there's some data out suggesting that also LAG3 might have an effect on the efficacy of checkpoint inhibitors, even if they are targeted to PD-L1 and not to LAG3. So do you think that a combination of checkpoints in the blood or in the tissue could be helpful?
I think there are interesting signatures in other tumor types, melanoma and lung, that come to mind that would be worth testing. Although, as you alluded to earlier, they could very well be very context dependent, and biliary epithelium may not have the same signature as for immunotherapy response. But yes, you're right. The combination is probably where we need to go. But I guess maybe I'll move on to the next section, and then we can put it on our, that we'll talk about some of the challenges, access to tissue in particular, as we think about these. So in the next section, I I wanted to present the data we do have on clinical trials of immunotherapy for cholangiocarcinoma, starting with monotherapy and then turning to the combinations that Arndt alluded to. So I think first, in a positive case example, we all have been, I think, highly gratified in the clinic to see patients with mismatch repair deficiency, or which is the cause of a phenotype called microsatellite instability, meaning a deficiency in these proteins called mismatch repair proteins leads to recurring defects or mutations in stretches of DNA called microsatellites that are genomic phenotype of the MMR deficiency, and one can test for either the protein MMR itself or mutation in MMR genes, or the phenotype being the microsatellite instability in these DNA stretches. So in the patients who have this, which happen to be only about 2 to 3% of cholangiocarcinomas, the proportion is much higher, say, in colon cancer, but in, say, cholangiocarcinoma, these 2 to 3% of patients have shown that they do achieve a dramatic and prolonged benefit from immune checkpoint inhibition, as we've seen in other solid tumor types. Here is an example from Keynote 158, patients with mismatch repair solid tumors. The objective response rate, including a subset of patients with cholangiocarcinoma, was 34%, with median overall survival in the advanced disease setting of around 24 months. And these responses were quite durable, and I think duration may not have even been reached at the time of this reporting. Now, I should clarify, this is a all-comer solid tumors with mismatch repair deficiency, but included over about a dozen patients with cholangiocarcinoma who were all well represented in these strong, durable responses. And so, based on the data from this and other similar studies, the US FDA approved pembrolizumab for deficient mismatch repair microsatellite high solid tumors as a tissue agnostic indication, meaning independent of where the tumor started, in 2017. And then after showing similar data for high mutation burden patients with TMB greater than 10 mutations per megabase, that was also approved as a tissue agnostic biomarker for use of pembrolizumab in 2020. Now, as Arndt mentioned earlier, the caveat here is we don't have a lot of patients with cholangio, or actually any patients with cholangio, included in this particular data set that led to the TMB approval. But I think we definitely had patients and have patients in the deficient mismatch repair context. So my take on these tissue agnostic approvals is that both MSI / MMR and TMB testing is warranted in advanced cholangiocarcinoma, and would be an indication to consider pembrolizumab in these patients. Now, turning to the 97% of patients who don't have mismatch repair deficiency or microsatellite instability, so that's the majority of patients, we see very different outcomes with immune checkpoint inhibitors as monotherapy. This slide reports on the Keynote 158 study, which was a large multi-center basket trial with a 104 patient biliary tract cohort, had central review of imaging. And this is for patients after at least one prior line of therapy. Here we can see PD-L1 expression was positive, either in tumor or microenvironment in 59% of patients. And almost all of the patients were confirmed to be proficient in mismatch repair, 5 were unknown. And here we see a very encouraging finding. I think it's very important to note that treatment-related adverse events, grade 3 to 5, were very rare, occurring in about 13.5% of patients. The majority were grade 3. And this is reassuring that there was no excessive toxicity in the organ dysfunction, biliary obstruction context, for example. And when we looked at, when we see this study's results, we see confirmed partial responses occurred in only 5.8% of patients overall. The number was slightly higher for PD-L1 positive, 6.6% versus 2.9% for PD-L1 negative, but both are under 10%. When patients experienced these responses, the duration was prolonged, but overall the median PFS was only 2 months and overall survival 7.4 months. So here's another agent, a PD-1 inhibitor, Nivolumab, in a multi-center phase 2 trial of Nivolumab in greater than or equal to second-line therapy. We see that the objective response rate by central RECIST 1.1 was 11%. This study was led by Dr. Richard Kim at Moffitt. with a similar progression-free survival being 3.68 months. Dr. Kim's group also showed a trend towards improved outcomes in the PD-L1 high population, with higher proportion experiencing prolonged progression-free survival with PD-L1 expression, but not enough for significance. So just to summarize, the immune checkpoint inhibitor data is monotherapy where it stands today. It is well tolerated. The adverse event rate is similar to other tumor types, but objective response rates are low in the mismatch repair proficient or a microsatellite stable population. And I think our benchmark estimate is around 6% objective response rate from the Keynote 158 data. And we've seen pretty similar outcomes for nivolumab, pembrolizumab, and durvalumab. When these responses happen, even though they're rare, though, they are quite meaningful and durable. So there are a subset of patients that do derive significant benefit, even though it's not as nearly as many as we'd like. And again, just to reiterate, though, that the patients with microsatellite instability high are just deficient mismatch repair, and we think high TMB have much better outcomes, and these biomarkers should be tested for in all patients with advanced biliary tract cancers, including cholangio. And the safety and the sort of modest efficacy, but potential for benefit in the monotherapy context has really prompted a wave of combination studies. How can we improve upon this 6% estimate? So for discussion, I wanted to pause here and ask Arndt your perspective on this trend, admittedly, limited for the PD-L1 expression in these two studies that I've shown.
Yeah, so I think it's not so convincing, right? I mean, there seems to be a trend, and but I think it's probably not really the best marker to decide yes or no. I mean, if in gastric cancer, it was also a back and forth going, right? And in the end, I mean, FDA did not use a cutoff as far as I know, but EMA for esophageal cancer, we have a cutoff, CPS score of 5 and even of 10 for pembrolizumab. But here in gastric cancer, in cholangiocarcinoma, I think it's even less convincing. So I'm not really sure. And I think the main problem with PD-L1 is that, I mean, we did some studies on PD-L1, well, we are still doing some studies on PD-L1 expression in cholangiocarcinoma, and we are just focusing on intrahepatic cholangiocarcinomas. And it's so amazing how heterogeneous these tumors are. Yeah, and it's not only between the tumors, which can be black and white. Yeah, it's also within a tumor that you have one area with a lot of immune cells, a lot of PD-L1 positive cells, and then areas without anything. Yeah, and if I mean, most of our patients that receive immunotherapies are in a palliative setting. Most of them have a biopsy, and I think there's such a huge error in just sampling and taking the biopsies that you really don't know to which extent the biopsy really reflects the whole tumor. And therefore, I think PD-L1, just because it's such an heterogeneous intra and inter-heterogeneous tumor, that it's not a good marker. And maybe it's a combination, what I mentioned before, maybe it's a combination of checkpoints, but yeah, we have to wait and see. And maybe I mean, we will talk about TOPAZ later. Yeah. Maybe we will have a chance to look at subgroups here. So maybe just one brief question. I think we can conclude that monotherapy is not really effective, but maybe one question to you. I mean, you showed the data for pembrolizumab in MSI cholangiocarcinoma. Looking at the data from colon cancer and the combination of nivo-ipi, ipi every 6 weeks, for example. So would you prefer monotherapy, or would you also go for combinations in the MSI subgroup?
So this is where I think it would be really interesting to develop some sequential studies or a strategy for this, because you're right, 30% or 40% is not 100%. And it may speak to heterogeneity, or not all somatic MSIs may not all be equal. But I think conversely, including patients in my own clinic, with a single agent therapy with minimal toxicity, I've had patients with complete responses now off drug for 4+ years, just from pembrolizumab alone. And so I'd hate to subject someone to extra toxicity if that were possible. So I think that's an area, though small sample size, very difficult to study with a 3% incidence of a rare uncommon tumor to begin with. But it invokes the model of starting with pembrolizumab, for example, or nivolumab, and then adding the CTLA-4 inhibitor if lack of response potentially, but not easy to study.
I agree. So actually, we only also have one patient, which I have seen in the last 20 years, and he actually also had a complete response after monotherapy. So that was really impressive. So you said you have more patients. So our patient had a family history, Lynch syndrome. Did you ever observe a sporadic MSI cholangiocarcinoma in your clinic?
Yes, I have. I think I have a couple patients with confirmed familial Lynch who have responded and had complete responses. I also have at least 3 somatic, sporadic microcellular instability we've tested germline, and the germline's normal, who've had complete responses, and durable complete responses.
Okay, perfect. So then let's move on. How can we turn cold tumors into hot tumors?
Right. So this cartoon just shows a snapshot of some of the ways one can try to turn cold tumors to hot tumors, or non-immunogenic tumors to immunogenic. So I've focused on some of the more basic ideas that have trials ongoing. So the first is using immune checkpoint inhibitors in combination with chemotherapy, which you can see sort of in this cartoon in the bottom left. The idea being, if you kill cells, you'll expose tumor antigens as the cells necrose, and potentially that will help the immunotherapy the tumor be more immunogenic to regional T cells. This may also suppress Tregs. The counter argument is you could say, well, certainly could also suppress activated T cells, but it could go both ways. The second approach would be to combine checkpoint inhibitors, as we were just discussing, such as adding a CTLA-4 inhibitor to a PD-1 or L1 inhibitor, with the idea of furthering the immune priming and activation. Another approach is to add a molecularly targeted therapy shown up here, where you target a particular tumor active pathway to help modulate and increase either tumor antigen exposure, or target the immune microenvironment by targeting immune suppressive elements within it. Or an interesting approach for liver tumors in general, including HCC, but also cholangiocarcinoma, is the fact that we do use clinically local regional therapy therapeutically already. And this way of killing a tumor by either radiation or arterial therapies might also expose tumor antigens in an immunogenic way and help immune therapy achieve a response. So these are some general classes of ways that we can combine agents to increase the chances of an immune response. So here's some data from Dr. Ueno et al. Published in 2019, looking at nivolumab plus chemotherapy. So that was GemCis, of course, in the first-line context. And with any combination with an active regimen like GemCis, we have to take into account that all of our endpoints in a single-arm study could be due to, we don't know the contribution of different component parts. So an objective response rate of 36% is encouraging. It's higher than we expect generally for GemCis, but in a small selected study, hard to interpret these numbers. But we do see that there is a complete response here in a subset of patients with prolonged responses. So encouraging, but hard to draw too many conclusions from a small study like this. Now, a study that caught all of our eyes a little bit more based on the dramatic objective responses reported was Dr. O et al.'s presentation in ASCO 2020 of the combination of GemCis with durvalumab alone or durvalumab plus tremelimumab, which elicited quite striking response rates of 73% with durva alone, or 73, same response rate for durva plus tremelimumab, both combined to the backbone of GemCis. These are much higher objective responses than we expect for GemCis alone. As I mentioned in the ABC02 trial, the response rate is around 25%, so strikingly higher. Encouraging duration and PFS a little higher than we expect from GemCis alone, though hard to interpret without a control arm. But this is a very provocative and intriguing study and warranted proceeding with phase 3 analysis, which we'll show the schema for in a moment. So based upon these phase 2 experiences, there are now two pivotal randomized phase 3, and then here's a phase 2 study looking at these questions in a randomized context. So the TOPAZ-1 trial, building upon Dr. O's work, examines gemcitabine plus cisplatin plus or minus durvalumab in a randomized phase 3 trial. The Keynote 966 study does a very similar design of pembrolizumab versus placebo with the backbone of gemcis. And then an interesting additional targeted therapy approach is taking the gemcis backbone, adding atezolizumab to both arms, plus or minus bevacizumab to evaluate the role of adding an additional anti-angiogenic approach. So these 3 trials are ongoing. The first of them, Topaz 1, as I showed you, here's the schema where again, patients are randomized to durva plus gemcis versus gemcis plus placebo with the primary endpoint of overall survival. And quite excitingly, just 2 months ago, or less than 2 months ago in October, the sponsor issued a press release that the combination of durvalumab plus the gemcis backbone significantly improved overall survival in Topaz 1 at the interim analysis. So this was an early look at the data suggesting significance, will be even potentially augmented with follow-up, although follow-up will be required to prove that. So this is a very exciting result, and we're looking forward to hearing this, the actual data at an upcoming meeting. Now, the schema for Keynote 966 is shown here, which is, again, a very similar study of gemcitabine plus cisplatin, but with pembrolizumab as the experimental agent. And this box should say with placebo. It's also a placebo-controlled trial with primary endpoint of overall survival. We don't have any results yet from this study. And lastly, here's the design of the gemcis plus atezolizumab plus or minus bevacizumab, with the bevacizumab being the differential bev versus placebo in the 2 arms. And in this phase 2 study, PFS is the primary endpoint. So changing gears a little, those are what I just showed were chemotherapy combinations in the first line. Now, if you recall, a different strategy of combination is to add checkpoint inhibitor to checkpoint inhibitor. So here is a study of durvalumab, PD-L1 inhibitor, plus the CTLA-4 inhibitor tremelimumab that was conducted by Dr. Ioka et al. And this was a predominantly Asian or exclusively Asian study with 65 patients enrolled. And the study showed treatment-related adverse events greater than or equal to grade 3 in 23%, which is an encouraging rate for the CTLA-4 combination, or acceptable rate, I should add, from my perspective. Confirmed partial response rate for the combination was only 11%, so not much higher than what we'd expect for durvalumab as monotherapy based on the pembrolizumab and nivolumab data. And overall, the PFS and OS don't give us much of a signal of efficacy from this small study to date. This, I think, were my conclusions from this study, that it's a higher objective response than the monotherapy by marginally higher. And there are ongoing phase 2 trials to learn a little bit more about this combination, but not a huge signal to date. Now, another study that has been published in JAMA Oncology from Ophir Klein et al. was a multi-center phase 2 study in a different population, and looked at the combination of nivolumab plus ipilimumab, and saw a much higher objective response rate in 2 of the subgroups, gallbladder cancer and an intrahepatic cholangiocarcinoma, showing 31% objective responses in those 2 groups, with admittedly small denominators, only 13 and 16 respectively. But again, the median PFS and OS were low, suggesting that the benefits are really occurring in just the subset of patients with response, not the medians, not reaching the medians. Immune-related adverse events, 15% grade 3 or higher. And I just highlighted these key efficacy data here.
So should we stop here for a second?
Yeah, I actually wanted to ask you a question about this slide, but you go first and then I'll ask my question.
So I think the data are very interesting. And as you have mentioned, I mean, the data from Dr. O are really impressive, right? I mean, this Korean group of patients, I mean, response rate over 50%, which brings me to my first question. So do you think that there's a difference between Asian patients and Caucasian patients? I think in HCC, we always have the same discussion, and you're also involved in many trials. So what do you think? Can we expect similar data also in a Western population?
So, going back to some of the early background slides, the reason I included that juicicle slide of the heat map showing different genotypes, gene expression, mutation burden with where they sorted out by epidemiology a little bit, I think it is intriguing that fluke infected and virally infected do trend towards having a much higher mutation burden, less of the single driver, simple mutations. And you're right, the story is very reminiscent of HCC here. One of the questions I have about the data on this slide that we don't know yet is what proportion were hepatitis B core antibody positive? We know, I think a small proportion were surface antigen active infection, but core antibody also does indicate that Hep B is probably integrated and maybe the etiology of underlying liver disease and the transforming event of the cancer. And so I think that's a key question of what proportion of these patients were truly what I would consider potentially Hep B driven as far as their original transformation. That still is a very high percent. It's still an incredibly encouraging response rate, but I agree with you that the Asian and potential viral etiology at hand or other environmental risk factors does raise the question of whether we're seeing a similar trend as what we're seeing in HCC.
And I think it's an interesting question, as you have mentioned before, with the fluke-like, I mean, they're kind of a little bit different, right? Also from the mutational profile, and they behave obviously a little bit different. And the point about hepatitis B is also very interesting. And I think, at least myself, I have never really completely understood, is it the hepatitis B or is it the Asian background, right? The gender, the race. So maybe we can have here a better idea. I mean, I don't really know how many patients are hepatitis B positive in the TOPAZ study, so we will see the data. So whether there's a different, whether it's more dependent on the virus infection or on the race. Yeah, so it's I think it will be interesting to see the differences between cholangiocarcinoma and also hepatocellular carcinoma, and whether we can draw any conclusions out of that.
I think as a field, we need to make sure we ask sponsors and ask ourselves when we do case report forms and enter, that we need to be scrupulous with collecting not just investigator assessed Hep B as etiology, but we need to be reporting Hep B surface antigen, what's the viral therapy, what's the core antibody total, what's the viral load, DNA, PCR, to have much more clarity on what's the true biomarker. If it's a virally mediated one, you're right, it could be pharmacogenomic or some other exposure that we're not aware of, but we won't know that if we have these missing gaps in our data, like with core antibody not being collected.
And the other question I wanted to ask you is about CTLA-4. So what is your take on CTLA-4 and maybe in respect for Durva and Tremi? I mean, we have this dosing issue, right? And I think AstraZeneca and maybe also we have the feeling that this 4-time dosing is not as effective as this 1-time dosing. Of course, we need to see more data, but also here for Nivo-Ipi, I mean, also the dosing schedule is different. So what is your overall idea and thoughts about CTLA-4 in cholangiocarcinoma?
So I think I don't know yet. You're right that both of these two studies here are using the Nivo 3 Ipi1, so relatively low dose of ipilimumab, and the Durva Tremi regimen was not the higher dose of Tremi that we have come to favor in HCC for its efficacy and immune stimulatory properties. I think it's intriguing to see this subset of responders, you know, in intrahepatic and gallbladder here is a nice number. But with small studies like this, it's hard to know, is this luck of the draw? And we don't know the TMBs, for example, of these patients or their viral status. So there's a lot of, as you alluded to at the very beginning, there's so many covariates that make cholangiocarcinoma so fascinating and so challenging that we really need to get all of those into our case report forms. But you know, without knowing those, I'd say there's a signal of some activity here, and I would like to see, you know, looking back, we have, you know, not quite as much to draw from in this study, but I would like to consider, say, that the single higher dose of tremelimumab would be an interesting question to look at.
And if you, I mean, it's just guessing. So if you would have the chance to redesign TOPAZ today, would you follow the same strategy, or would you add one-shot high-dose tremelimumab?
I think if I were doing the, Dr. O's study preceded our data from HCC on this question. It would have been very interesting to conduct her. So her study, as you well know, didn't show any clear difference between the durva and durva-tremi arms, but with the lower dose tremi, it would have been quite interesting to try the single high dose in that arm. That would have been the place to study it in the randomized phase 2 context. Would have been a great place to look for a signal there.
Actually, there's one study who did this actually, who compared low dose tremi versus high dose tremi versus durva alone. Do you know who conducted the study?
In cholangiocarcinoma?
Yes.
Oh, I'm embarrassed that I don't know. Did you do it?
Yes, I did it. But we have not yet reported it, so you can't know really. So we finished the recruitment last year, and last year, and we are now in the final process to look at the data. So I do not yet have the final data, but we will report hopefully early next year at ASCO maybe, and then we will see whether there's a difference with single high dose versus 4 times low dose tremelimumab in a Western population. It was thought as a proof of concept study with 20 patients in each arm. So it's a small phase 2 study, really seeking for a strong signal. We will see.
Oh, that's a great study. I definitely applaud that study, and that's the kind of thing we would need to see to compare these. Yeah.
Okay, so we're running out of time. We need to move on. Are there other strategies to improve outcome?
Yes. So another randomized study that has been reported on looks at, moving to a different approach. We just talked about dual immune checkpoint inhibitors combining an immune checkpoint inhibitor with a targeted therapy to modulate either tumor signaling or the immune microenvironment is another approach to combinations. And this slide shows the rationale of inhibition of MEK, which may increase class 1 MHC expression on tumors to help antigen presentation, may also help reduce T cell exhaustion by inhibiting MEK in the TCR signaling cascade. And so these are the preclinical hypotheses for targeting MEK, though targeting MEK as a monotherapy has not been successful in cholangiocarcinomas. So the trial here with combining with a checkpoint inhibitor atezolizumab was conducted by Mark Yarshuan and Nilo Azad through the NCTN structure through the NCI, and was a randomized phase 2 trial with the arms shown here, atezolizumab alone versus atezolizumab plus the MEK inhibitor cobimetinib. Let me show you the results here. So the red is the combination arm and the blue is single therapy. And though they diverge, these numbers are unfortunately much lower than we'd hope. The median was measured in days, 57 days for the single therapy versus 111 days for the combination. So it was significantly improved, though, again, both modest from a PFS perspective, and objective responses were rare in both arms, 3 versus 2% roughly, or both around 3%, I should say. So again, not a strong signal of efficacy, unfortunately, from this randomized phase 2, but obviously we applaud the design of this to conduct and enroll a hypothesis-driven combination so quickly. Was fantastic, and based on the correlative analyses that were very, very carefully collected from both arms and conducted through the teams, they've identified potential triplet agent, a CD27 agonist that may be a complementary approach to add to the combination. And so that's a study that Dr. Yarshuan described at the Chlangiocarcinoma Summit earlier this year, and will be eager to see results of that next strategy on the horizon. Another targeted therapy combination, which unfortunately also has not been a success to date, was combining PD-L1 with TGF-beta inhibition through a bispecific monoclonal antibody M7824 or bintrafusp alpha, which showed an intriguing signal of objective responses in a phase 1 all solid tumor trial in the cholangiocarcinoma subgroups, biliary subgroups, I should say, with responses shown here in this sort of this waterfall plot, I guess you'd call it. And so that prompted development of a larger phase 2 trial, which was a monotherapy which completed enrollment and unfortunately just last spring reported out objective response rate of 10.1%. Again, very similar to what we expect from monotherapy without the TGF-beta trap moiety of the bispecific antibody. And this did not meet pre-specified thresholds, so it was declared a negative study. In parallel, the same agent had been in a randomized phase 2/3 in the first line combined with Gemcis as a chemo combination. And unfortunately, quite recently in August, the IDMC discontinued the trial based on prediction for lack of reaching its endpoint. So these two trials have closed. Now, another combination approach that we've used certainly in hepatocellular carcinoma and a lot of other tumor types, renal cell carcinoma being another poster example, is the combination of checkpoint inhibitors with anti-angiogenic therapy. Here's the combination of pembrolizumab plus lenvatinib, which was studied in a second-line biliary tract population, again, a small cohort, 32 patients, which includes a mix of intra-extrahepatic and gallbladder. And what we can see from this, again, small subgroup analysis, or small, not a subgroup, but a small cohort analysis, where objective responses occurring in 25%. So that's certainly higher than that 6% of pembro alone, which is intriguing. And a disease control rate of around 78% in this cohort. And so this is one approach to keep on our horizon. Now, there are turning to, actually, I should add, there I think is an ongoing basket trial or soon to activate basket trial taking the same combination and adding a third targeted agent, a HIF-2 alpha inhibitor called belzutifan, building upon the data here of the doublet, which we can keep our eyes on in the future and perhaps report at a next meeting when we have some data, but it's just activating now, sponsored by Merck.
Could we pause here for a second?
Yeah.
So I think with the targeted therapies, it's really interesting, and I agree. The study with cobimetinib is really, I mean, the preclinical data look really convincing, right? And the idea to target the immune cells and maybe a little bit the tumor cells with the MEK inhibitor, and it's really sad that it didn't work out. And in colon cancer, unfortunately, the same negative study. So this concept, even driven by good preclinical data, just failed in the clinic. So I think in hepatocellular carcinoma, we are at the moment combining everything with everything, is my feeling, right? I mean, so whatever TKI you have, you combine it with whatever checkpoint you have, and pembrolizumab and lenvatinib, as you mentioned, seems to be quite effective, right? And in the COSMIC study, we just learned that ESMO Asia was not so convincingly positive. I mean, it was half positive, but overall survival was not improved for atezolizumab and cabozantinib. So do you think we can proceed here in a similar way with cholangiocarcinoma, or we need to be a little bit more driven by preclinical data, even if it has failed in the previous study you have shown? Do you think we could also use other TKIs here in this setting?
Well, I guess there's a huge difference between cholangiocarcinoma and HCC is that the TKIs have monotherapy activity in HCC, and while regorafenib has shown there's been some modest monotherapy, they're really not established in randomized trials prospectively as achieving a survival benefit to date for any of the tyrosine kinase inhibitors, and so that's one difference. I guess in HCC included, I think the big question is whether we're seeing additive effects or synergy, and whether you and I have talked about this before because it's such a glaring.
I wanted to ask you.
Yeah, and so I think that what we might be seeing with some studies, including some of the HCC studies, is we see some immediate disease control and maybe some PFS benefit from the TKI that has sort of a more modest effect, but across all patients. And then we get these home runs in a small subset at the end. And I'm not convinced yet that we have data to prove we're seeing synergy. I don't know. What do you think? What's your latest thoughts on this question?
This was my question I wanted to ask you. So I think I cannot add more, and I completely agree with you. I mean, I'm also not convinced about synergy. I think we are always hoping for synergy, but I agree with you. I think we need more evidence for that. Yeah.
I think though in HCC and cholangiocarcinoma, if we do have at least additive benefits, that's still wonderful, because patients have limited chances at treatment, and we don't want to miss a window of opportunity if we can get benefit from both drugs together. The big question is making sure we're not seeing a detriment, because it's hard to tell. We can't tell if we're actually getting less than each drug alone without a randomized, good quality randomized trial. So more to come, but I think this is intriguing, though very early. Then this table is the next slide, just focuses on what's on the horizon for a combination of local regional therapies. There's trial of durvalumab plus tremelimumab plus ablation, durvalumab plus tremelimumab plus radiation, durva-tremi with Y90 radioembolization, and then Nivo plus radiation plus or minus ipilimumab. So some very interesting, rather large studies when you consider for single arm local regional therapy combination. It's not all of them single arm, some are plus or minus, some are randomized here, but it'll be quite interesting to see how these report out and get signals from them, though difficult to interpret when there are 3 different interventions being undertaken, and not all of these are randomized, just the bottom 2. Oh, go ahead.
So I know the third one quite well. So this is actually also a study we have initiated here in Germany, and we have a randomization 1-to-1 for plus minus tremi. And as you said, it's really extremely difficult to recruit these studies, because I mean, you need a liver limited tumor, at least in our study, which is mainly intrahepatic cholangiocarcinoma. Then you need, if you do the dosimetry, you need to really get high dose radiation into the tumor and save the surrounding liver. And the 50 patients is really a challenge. I mean, we have, I think, 7 or 8 now. So, I mean, we are making a little bit progress, but it's really difficult. Yeah. But I think the idea, combining radiotherapy, I mean, it could work. We don't know, but it could work.
What dose of tremi are you using?
The high dose.
Oh, good. Just single high dose.
Yeah.
Great.
Yeah.
Excellent. I think I'm getting to the questions for you next. So just to summarize the immune checkpoint inhibitor combinations, where we are, we discussed that we have chemotherapy or GemCis plus immune checkpoint inhibitors in the first line are ongoing. The combination of GemCis plus durvalumab improved OS in the TOPAZ-1 trial based on the press release that was issued in October, and we're eagerly awaiting the presentation of those results in an upcoming meeting. And what we just talked about were other combinations that are ongoing, and there are many others, including the dual checkpoint inhibitors, the checkpoint inhibitor plus targeted therapy, and checkpoint inhibitor plus local regional therapy. So a lot of data and hopefully more information on our horizon. And this is where I was going to ask Arndt, what else would you add to this list of the watch list of what to stay tuned for?
Yeah, so I mean, this is already a very comprehensive list, and there's not much left. I think the only thing that might be left would be the combination with targeted therapies in the specific genetic subpopulation. Yeah, for example, for the combining FGFR inhibitor for the FGFR2 fusion patients, I think at ESMO there was a study in bladder cancer or something like that. I mean, where they also combined FGFR inhibitors with a checkpoint inhibitor. So I'm completely not familiar with this field, but as I understood the data, it seems to be, there was some signal, but the question is, can we extrapolate this to cholangiocarcinoma? It's difficult to say. And the other point would be IDH1 mutations with a checkpoint inhibitor. I think there's some preclinical data, at least for glioma with IDH1 mutation and checkpoint inhibitors, and it appears to be promising. So that would be the only missing point here, whether in this genetically defined subgroups, whether we can combine targeted therapies with checkpoint inhibitors. So do you have any experience with that?
Not experience yet, but I do think that for example, when we look at trials like Keynote 158, and in the future, when we look at TOPAZ-1 data, I think it'll be, like TOPAZ-1 will be harder to interpret because it has chemo involved as well. But I think we really need to look at mutation subsets to understand if certain mutations have better or worse responses, or more or less likely to respond to immune checkpoint inhibition, given again the premise that some of them may be more or less immunogenic. So I think we just need to make sure, I think one of the challenges of when we have our initial foray into a treatment and new immunotherapy as a basket trial, where one cohort is biliary and the next cohort's bladder and the next cohort's triple negative breast cancer, is that all of the clinical annotation that we need for cholangiocarcinoma, like intrahepatic, extrahepatic, gallbladder, is not captured because these are just big platforms designed for 20 different tumor types. That's the case for Keynote 158. We don't know how many were intrahepatic, and we don't have FGFR2 fusion data. And so I think we need to try to make sure we, when we lead trials like this, or when we're part of them as investigators, to try to ask for tailoring of the case report form collection of data towards cholangio, so we can have this data and make progress with it.
Yeah, so I completely agree, and I hope we will get these data. I mean, if you have a positive study, I'm not sure whether the company is so interested in subgroups, and if it's a negative study, they're also not interested in subgroups. Yeah? So it's kind of difficult. Yeah, but I think it's an interesting question. I mean,
if we do it at the time, at the beginning, when we're doing this, if we ask them, modify or collect this, please.
Collect it, yeah, and yeah, we will see when it is reported and how it is reported. Yeah, but the question is, how do they respond differently, and can we combine targeted therapies? Yeah, and I think this is an interesting question. But I think we are running out of time, so you need to move on, right?
Yes, I have just a couple slides and then just a couple questions for you. So this is really a summary of all the things that we've been organically discussing along the way. What are the challenges in the second line? We've already talked about this, the heterogeneity across the board, comorbidity, we didn't talk about this, but measurability can be a challenge. And I think this is sometimes like extrahepatic tumors that often are amorphous and just sort of soft tissue masses don't have as good of a response rate necessarily. So we don't want to miss a signal just because they're not measurable. And then the lack of tumor tissue. So these are all some of the common challenges that we've alluded to, but also some key opportunities. And I think this is, from a pragmatic perspective, the fact that we don't have a gangbusters treatment in the second line or third line. You know, we have FOLFOX and we have FOLFIRI, but I think that is a ripe area to do research, because I feel very comfortable talking to patients about, let's try this. We can use FOLFOX later if it doesn't work. We also can consider in some cases placebo control, which is much more potent of a signal finding exercise if we carefully make sure we include crossover designs, for example, as the AG120 Agios to ivosidenib trial did. I think on the horizon, we may have better response metrics and signal finding with novel imaging approaches. I think the difficulty of finding tumor tissue, we finally have better technology for non-invasive biomarkers. And the ability with these tools to start looking at subgroups because of this heterogeneity. So those would be the opportunities I see for progress on the horizon. And then I'm just going to skip this slide. And I think, maybe Arndt, I was going to ask you real quickly, what do you think is the optimal control arm? I'll ask that quickly because that's a short one in the second line.
Yeah, very good question. And I think it depends a little bit, most likely, where you are in the UK or out of the UK. I think FOLFOX is somehow the standard of care in second line. Personally, I'm not completely convinced. I mean, so we treat our patients until progression in the majority of cases, and then switching directly from cisplatin into FOLFOX, I don't know. And so I think the nifty data were quite interesting with irinotecan. I mean, there seems to be efficacy for irinotecan in cholangiocarcinoma. So I don't know. I mean, the question is how the trial would be designed. Yeah, is it a combo of chemo plus checkpoint? Yeah. Or is it, as we just have discussed, a targeted therapy or TKI or whatsoever plus checkpoint or dual checkpoint inhibition? Yeah, and actually I think the efficacy of all these chemotherapies is so limited, in the end it doesn't matter, right? So it could also be dealer's choice. I mean, if you do not add on, you could also argue it can't get worse. I mean, and if something is really meaningful, it should be better than either FOLFOX or Naliri. Placebo, I think, would be difficult. I mean, at least in Germany, and I guess also in the UK. I mean, a placebo would be difficult.
And then maybe I'll ask the last one. Should we be selecting, which do you want to talk about, this one or the question before?
I think we touched a little bit on these questions before, and I think the subgroups are too small, right? MSE, MSI. I mean, you said 3%. In my experience, is less than 1%. TMB is extremely low. Viral hepatitis, I think, is interesting, and we will get more data, hopefully, from the TOPAZ study to better understand the impact of hepatitis B infection and cholangiocarcinoma and the sensitivity for checkpoint inhibition. And what was the other point on yours? Targeted therapies. I mean, the targeted therapies, I still think, I mean, we also discussed it already. I mean, that could be the TKI we are using in HCC. I mean, we have these just TKIs unselected. In cholangiocarcinoma, we have these targeted therapies, but this would be the question. And here, same story. If we just have additive effect, it would be fine, right? I mean, if we would combine an FGFR inhibitor with a checkpoint, and if we could improve the PFS from 6 months, as we have seen it before, to 9 months, I mean, that would be meaningful.
Great. Well, maybe I'll go to the conclusion slide because I think we're out of time. So I just have.
But we are allowed to go over a little bit, so don't worry.
Okay.
Therefore, I continued talking because, I mean, but let's come to the conclusion. Yeah.
I'll come to the conclusion. Then
don't hurry. Yeah.
Okay. So as we've just talked about, there are a lot of combination approaches being studied, which is really exciting, and I have great optimism for the future. We're waiting on the results from several large randomized trials and a couple of large phase 2 cohorts. So I think the first conclusion is we have the TOPAZ 1 regimen, and we're all waiting with bated breath to see the details of those results and whether there are any, as Arndt alluded to, are there differences between the Asian versus non-Asian populations within TOPAZ? And will this become our new standard in the first line setting? We also have ongoing trials and trying to figure out how best to leverage these other combinations. Now, I think, this is what we've touched upon already, that it's very difficult to assess the component contributions, whether a combination is additive or synergistic. And the important goal is to make sure it's not detrimental. So additive would be, adding drug 1 plus 1 drug, the second drug, and getting a 2. Synergistic would be adding drug 1 and another drug and getting a 3. But detrimental is, adding a drug and another drug and getting 1.5. And we can't tell that from single arm studies. And so that's why, or even randomized studies, unless we have good stratification. So it's very important that we design these trials as carefully as possible. And ideally continue our efforts to find biomarkers to help understand the mechanisms of response. In future, as we've talked about, I think owing to the enormous heterogeneity, we need to carefully annotate our trials to be able to look for signals in subpopulations. And that includes not only the anatomic subsite, but all of these variables that we've talked about. There are probably many others that we don't know about yet, but including genotype, viral status, race and ethnicity. We haven't talked about histology yet, mass forming versus the pattern of tumor, but all of which may have important biologic relevance. And there's a lot of research on the horizon. So I think this is going to continue to be a topic of great interest and progress for years to come. And we're just scratching the surface right now. But TOPAZ is an enormous landmark, which hopefully we'll see next month. And that's it.
Okay, perfect. So thank you very much. I think it was really an excellent talk, and I really enjoyed it a lot. It was very comprehensive, a lot of data. So great talk. Thank you very much. And as you have mentioned, we are running out of time. So I think we should hand over to Donna, right? And get some goodbye from her.
Yes. Thank you both, Dr. Kelley and Dr. Vogel, on behalf of the ICRN for this very informative and very interactive discussion. And I want to let everyone know that's on the participating in the webinar that it has been recorded and it will be available on the Chlangiocarcinoma Foundation website. And thank you to all of the attendees who participated. We'll see you again in January.
Thank you.
Thank you, Arndt.
Thanks, Kathy.